Ellissa Baskind, who is a consultant in reproductive medicine and surgery in Leeds, where she's the clinical lead for reproductive medicine. She has an interest in genomics and is the clinical lead for PGT in Leeds, which also covers the north of England and is also the clinical lead for genomics in care fertility. She's also a member of the NHSE PGT advisory panel, so very, very experienced to give us a talk on PGT. So Ellissa, if you're able to share your slides.
Oh gosh, now you're asking. Hang on.
If you want me to share your slides, I can do that for you.
No, it's fine. I will figure it out. Hang on. Where are we?
Yep. So you just hit share and then window if your slides are open.
I've got it. I've got it. I just need to get it onto the right screen. Hang on. Let's do a slideshow. Where are we? Just bear with me. There. Let me switch that around. Hang on. Just bear with me. I'm having some technical issues. It's just I want to share the other screen and not this one. So let's try that. There. Have you got that now?
I do. That's perfect. Thank you.
Yes, that's great.
Lovely. All right, so let me just go back to the beginning. Right, thank you so much for the introduction, and I'm sorry about the technical issues. So yes, I got a real interest in genetics and reproductive genetics. So what I'm going to do today is try and cover a little bit of what I do in my day-to-day job, and in particular, I've been asked to talk about pre-implantation genetic testing, and I'll explain to you what that is all about. So we'll talk a little bit about genetics, what is PGT, what happens during a PGT IVF cycle, a little bit about the risks of PGT as well. So I suspect that most of you in the audience are very familiar with the basics of genetics, but actually explaining genetics to patients is really quite challenging. So just sort of like to share with you what I tell to patients. So I always say to patients that we all have a genetic code, and the genetic code determines who we are, how we look, how we behave, and how all of our organs work. And the code is written down in a series of books, and there are 2 volumes of each book, one given to you by mum and one given to you by dad, and these are your chromosomes, which come in pairs, and within each book are pages. There we go. Within each book are pages containing words and sentences, which are like your genes, and each word is composed of letters which are like DNA. So this is sort of an analogy that works quite nicely with patients. Here you can see we've got 23 pairs of chromosomes in decreasing size order, ending with the sex chromosomes. I'm sure you've all seen this picture before. Pre-implantation genetic testing. This is where we sample cells from an embryo, a pre-implantation embryo. Essentially, we're testing them to see what's going on from a genetic perspective. And there are 2 main types of PGT, and I'm only going to be covering one of those in today's presentation, and that is going to be this PGT-SR or PGT-M. This was previously known as pre-implantation genetic diagnosis. It's now changed to pre-implantation genetic testing. This is funded by the NHS, and there are 2 particular types. One of these is PGT-M, and the M stands for monogenic, and this is where we're looking for specific single gene disorders. And the other one is a PGT-SR, and the S and the R come from structural, and that's where we're looking for chromosomal translocations. What I'm not going to be talking about today is PGT-A, pre-implantation genetic testing for aneuploidy. This used to be called PGS, pre-implantation genetic screening. There isn't any NHS funding for this. This is, a test so that we can help select the best embryo for transfer when we're doing an IVF cycle, and it can be offered to various different groups of people. And I don't have the time to go into that in any detail today, but we can come back and do it another time. Let's talk a little bit about PGT-SR to begin with. PGT-SR, like I say, is for structural changes. And here you've got two chromosomes side by side. So imagine you've got on the left here, you've got chromosomes 7 and 10, and that's from a normal person. And then you can have a balanced translocation. So this person on the right has got the right amount of genetic material. You've just got a little bit of chromosome 7 switched over with a little bit of chromosome 10. So you've got all the right amount of genetic material. So this person functions completely normally and has no issues at all until they come to making their eggs and sperm. So when the normal person makes eggs and sperm, there's sort of only one option where the eggs, the sperm are going to have the right numbers of chromosome in them. But when you have a translocation, there are various different combinations of eggs and sperm that you can make. And then when those fertilize together, you can either have a normal embryo with the right number of chromosomes, and that's completely normal, or you can have an embryo that's created that's balanced like the parent, and that will also have no issues until they themselves go and try and have children, and they might have issues with infertility or recurrent miscarriages. Or you might have a little bit too much of one chromosome or a little bit of one chromosome missing. So those two, like I say, would result in a normal phenotype, whereas these two will not, and will either end up with a failed implantation or a miscarriage. So we can do PGT-SR to try and identify embryos that have got the right number of chromosomes. What we can't actually do at the moment is we can't differentiate between those two middle embryos. We can't tell the difference between them. So we don't know if when we're replacing an embryo, which we've done PGT-SR, if we're actually causing or the child that will result from that will have a balanced translocation like their parent. And so that's something that we need to counsel them about, because they might have reproductive issues when they get older. I think it's just really important to mention the difference between PGT-SR and PGT-A. And this sort of, if you look at it from sort of maternal age perspective, that's really helpful to remember it like that. So if you've got a balanced translocation, it's absolutely not related to age. It's an inherited condition, and however old the mother is, and it could be the father as well that's got the balanced translocation, there will be a risk that they will have fertility or miscarriage issues. And we also know that there is a specific change in the chromosomes that we know about before we get started, and this is where PGT-SR is valuable, and we can identify those embryos. For those patients that are having PGT-A, that's generally, like I said, in groups of patients. In particular, we offer it to women who are older, because we know that there is a higher incidence of aneuploidy, and that's sporadic, and that's related to age. It's not inherited, and there isn't a specific change, so you could have any chromosome involved and any combination of chromosomes involved, and that's where you would do PGT-A, and that's a screening test rather than a diagnostic test. So I want to move on to PGT-M, which is pre-implantation genetic testing for a single gene, a monogenic disorder. And you can see here you've got two strings of DNA there, and just wanted to sort of show you that if you change even a single letter in your DNA sequence, it can have an impact on the meaning of the DNA. So if you have a look at this sentence, the sun peeked through the tall trees, it gives you a nice image. But if you change the S to a G, you've got the gun peeked through the tall trees, and it really does change, what that sentence means. It's very similar with DNA. So I wanted to talk to you a little bit about PGT-M from sort of a clinical perspective. This is very much my area of interest. So the commonest PGT we do is for single gene disorders, and I've been doing this since about 2016 or so. I wanted to tell you about this child, and sort of where my interest in PGT came from. Really was around this particular child. So I don't know if you know, this child has got a condition called harlequin ichthyosis. It's a severe autosomal recessive disease, which causes very thickened skin at birth. And it can really affect the way they look, but also it has internal consequences. They have difficulty breathing due to a restricted chest wall, and they don't do very well. Half of them will die within the first year. So I met this, I was having some chiropractic treatment, and you know what it's like when you're sat with a therapist and you have a chat and you find out what you do for a living. And he was telling me that he had a baby. He'd already had one child who was perfectly healthy, and then out of the blue, their second child was born with this condition. And obviously it turned their lives upside down, and they were both tested, the mum and the dad, and they were both found to be carriers of this condition. And they were advised that there would be a 1 in 4 risk of recurrence. And they saw a genetic counsellor who said to them, there's a chance that you might have this again, and we can do testing within a pregnancy, prenatal testing with an amniocentesis to diagnose if the pregnancy is affected, and if it is, then you might think about having a termination. And so they went on and had another pregnancy, and then I think that there was an affected pregnancy, and they had a termination, and then they had another pregnancy again, and this time around it was unaffected, and they got the third child, who is now very healthy. But what really struck me was that this family didn't know about PGTM. They didn't know that this was an option, and they went through a lot of trauma, having had to go through a TOP. And it just sort of made me realise that, I do this on a day-to-day basis, but perhaps not everyone knows about it. And so kind of a bit of my mission is to spread the word and make sure that families know that this is an option. So who is offered PGT SR or PGTM? So these are families where they've had a termination for a pregnancy for a serious genetic condition, like we just mentioned, or they've got an existing child with a serious genetic condition, again, like the last one I mentioned to you, or either parent has a serious genetic condition, so it could be autosomal dominant, so the parent already knows. For example, I saw a patient this morning who's got Marfan's, and they want to have another child, they want to have a child that's not affected by that condition, or both parents might be carriers of an autosomal recessive serious genetic condition like the ichthyosis that we just talked about, but there are lots of other lots and lots of genetic conditions that people can be carriers for. In the UK, it's illegal to use this type of testing to select embryos on the basis of their sex for social or family balancing reasons, but you can consider it in certain sex-linked disorders. So I think it's really important that patients are made aware of that. We're very closely regulated in the UK. The HFEA considers every condition that we would like to do PGTM for, and really seriously considers whether it is a serious enough condition to warrant PGTM. And there are a list of hundreds of conditions that have been licensed over the years, and we sort of on a regular basis are asking for further licenses for different conditions. This is very different to other countries. For example, in the USA, they don't have that same sort of regulation, and they might do PGTM for conditions that the HFEA just wouldn't feel are serious enough about, which does sort of raise the issue of eugenics, which I think the HFEA is very good at, regulating. So the other questions that I've got on this slide is, does PGTM detect any other problems? At the moment, no, we are only looking specifically for the genetic condition in question. That might be something for the future if we're able to do some more extensive whole genome or whole exome sequencing on embryos. That might change, but at the moment we are only looking for this specific condition. And does PGTM detect whether the number of chromosomes is correct? Well, it depends whether or not you do PGTA in addition to PGTM, and most centres do both, because I have, in my experience, I've seen a couple of patients who've come through and they've had their PGTM for the genetic condition in question and ended up having babies affected by Down syndrome. I've seen it twice. So if we are able to do genetic testing for the single gene disorder, it makes sense to also be testing for aneuploidies as well. PGTM can be, like I said, be performed on thousands of single gene disorders. These are the common ones that we do. So the BRCA genes, cystic fibrosis, Fragile X, SMA, Huntington's disease, sickle cell, but there are lots and lots and lots that come through the service. And like I say, in the UK, they need to be licensed by the HFEA. There's about 800 that are licensed at the moment. It can take quite a long time to process a license, and patients do need to be counselled about the timeframes that these cycles take. So how does it work? So if you want to have PGTM, you need to, or PGTSR, you need to see a genetic counsellor, and we've got an amazing group of reproductive genetic counsellors in the UK. We're very fortunate. It's a fantastic service, and there are lots and lots of very, very rare conditions, and because they talk to each other, you know, they learn from each other, which is very valuable. So they'll discuss with the patients the mode of inheritance, explain to them the difference between autosomal recessive and dominant. They'll talk to them, excuse me, about the alternatives to PGT, such as a natural pregnancy and prenatal testing, which is the ichthyosis case that I mentioned before. For some patients, they don't want to do that. They would go down the donor egg or sperm route, or even donor embryos, adoption, elective childlessness, if they don't want to have any intervention at all. And then they will talk to them about the PGT process and the funding regulations for it. And if there are the basic requirements, if they meet them, they will then refer them to a PGT fertility centre. So the NHS England policy for PGT-M and SR is very outdated, and hopefully that will be amended over the next few months or a year or so. It's funded by NHS England, so as I'm sure you're aware, there are some issues there. So it's a little bit grey at the moment. But at the moment, we're following the 2014 policy where women have to be less than 40. They have to have a normal BMI, be in a stable relationship. They have to have no unaffected children as a couple. So unlike with lots of ICB funding, if a couple have got a child, if they've got a child from a previous partnership, they would still be eligible for NHS England funding for PGTM. They mustn't be using PGT primarily for fertility treatment. They need to not be smoking, and it needs to be a condition that's licensed by the HFEA. And the cost of PGT is about £15,000. We've recently had to incorporate the overseas changes, which I think a lot of the ICBs have been dealing with of late, and it's having a big impact on our patient. We have a lot of patients who are from overseas who have got autosomal recessive conditions, particularly consanguineous couples, and if they don't have the right visa in place, we're no longer able to treat those patients, which is a real shame, because the cost to the NHS for these families, if they do have affected children, is very high, as you can imagine. Let's move on. So, as I said, the pathway, you would need to be seen by a genetic counsellor, and they would be referred to a regional genetic PGT centre. And there are 5 centres in the UK: Guy's, CRGH, Birmingham, Oxford, and Nottingham. And there are, I've put Leeds as a satellite to Guy's. There's quite a few centres which satellite to Guy's Hospital. So Leeds is one of those. But patients do have the option as to where they would like to go. There are discrepancies between the different clinics, which is frustrating. And one of the reasons why we set up the NHS England panel is to try and make it more equitable, and patients hopefully will be able to get an equal service wherever they go for their PGT treatment. And one of the things that I'm working on, I have been working on sort of campaigning for a number of years is trying to get funding higher up in the north of England, because you can see on that map there's very little, in fact nothing, south of Nottingham, I should say. Which is really inequitable for patients, because they have to pay for travel and transport and accommodation when they go to their treatment centre, and it does feel very unfair. They often have sick kids, and they themselves are disabled, so it's really difficult. So I am encouraging patients to write to their MPs to try and raise the profile for this. So what are you eligible for if you have PGT? So very fortunately, patients are funded for 3 complete cycles. NHS is quite generous in this respect, because there is a realistic possibility that they could have a cycle and all of their embryos are affected by the condition. It's like tossing a coin, particularly for an autosomal dominant condition. So they just need to get back on the horse and come back and start again if all of their embryos are affected. It is at our discretion, though, and if they've done really badly and they're not going to get any eggs in another cycle, we will not sort of progress to another cycle, because we have to be sensible. So just some basic requirements. One thing we advise patients is that they have to use contraception once they're committed to having PGT IVF. They can use hormonal contraception, but it's better to use non-hormonal and barrier contraception during the PGT cycle. So it's better to sort of start with that before they get going, and it's better for us to do our investigations if they've not got any hormones, so we can get a very accurate assessment of their ovarian reserve. There may be potential problems, some of which need to be addressed before we can do the PGT, some which can wait. And there are obviously some conditions that are associated with the genetic condition. For example, Fragile X may be a consequence of, diminished ovarian reserve may be a consequence of Fragile X. And for men, commonly we see CBAVD with cystic fibrosis, so there can be sort of a genetic cause for a fertility problem. A lot of our patients, particularly if it's the female partner, need to see have a preconception and anaesthetic review before starting treatment. We have some really high-risk patients, a lot of cardiac issues, and we have to be safe. And there are some patients where we would recommend surrogacy because it's not safe for them to have a pregnancy because of their genetic condition and medical consequences. We often have to seek medical input, and they may require quite intensive counselling about the risks. So we need to design a test. So we would get a buccal swab from the sample from both partners, and we might need swab samples from other family members, so that the genetics lab can design a probe that's very specific for that patient. And sometimes if we haven't got any samples from relatives, which does happen, we need to do direct embryo testing, and sometimes we need to actually take them through a cycle of IVF treatment, test the embryos, and then that will help us design the test, and then we need to take them through a second cycle of IVF to get more embryos so that we can use the test that we've created in the first cycle. So it can be quite long-winded, and I think that the take-home message really is that this is not a quick treatment cycle, and it can take a number of years even before a patient, from the moment of referral to when they've got a baby in their arms, it really can take over 2, even 3 years before that point, because so much has to happen. Just to very briefly run through this, you'll be familiar with the first steps of this. When an embryo is 5 days old, it contains about 120 cells, and we can look down the microscope and identify which of those cells are going to become the tropoectoderm, the placenta, and we can remove 5 of those cells, and those then get sent off to the genetics lab where they're analysed. Meanwhile, the embryos themselves are frozen. And depending on which lab you're using will determine how long it takes. There are some labs where we get the turnaround in about 4 weeks for the results, others where it can take up to 8 weeks. So this is just the biopsy being taken. I think, yeah, a little slide. I don't know if this is going to work. There we go. So this is an embryo being biopsied, So you can see that the little orange circle, if you can see it, is the laser, and the tiny little hole has been made inside the embryo tropoectoderm wall, the zona, and then they're just removing those cells, breaking off. It's remarkable how that then will just bounce back, and then those cells are then sent back to the lab. And we get the results, and obviously you can see that there are various different outcomes, and we would obviously only transfer the unaffected or carrier embryos. So results with autosomal dominant conditions, about 50% will be affected. So like I say, it's a bit like tossing a coin with autosomal recessive conditions. About 25% will be affected, 25% will be unaffected, and 50% will be carriers. We do transfer carrier embryos. PGT is there not to stop a condition. It is there to give a couple a healthy baby. We're not going to eradicate the condition. If we didn't transfer carriers, we would just not have embryos to transfer. We would never really get enough pregnancies. And then obviously we can do it for X-linked conditions as well. We do sometimes do it for more than one condition. That is not that we do that every now and then. And the more conditions you're testing for, the fewer the embryos are that you're going to have to transfer. So outcome, test itself is about 98 to 99% accurate. It's not 100% accurate. Therefore, we do offer prenatal testing. Success rate is very much dependent upon the maternal age. And then just a note about risks. We might not get any embryos to biopsy. It's a realistic outcome. We might only have affected embryos. Again, we see that. We have to jump back on the horse and start again. There is a risk of misdiagnosis. I've said it's 98, 99% accurate, and so they may want to have prenatal testing. There are risks in the cell biopsy procedure. About 1 in 100 embryos get damaged in the process of the biopsy, and we can't resurrect a damaged embryo, very sadly. And it may be that the lab can't process the cells that we've got, and sometimes we get a genetic diagnosis, and so we can thaw the embryo and take a second biopsy, and we have had plenty of pregnancies where there's been 2 biopsies, and sort of the long-term outcomes have been very good. So there are some increased risks within a pregnancy as well. The background risk of preeclampsia of 2% goes up to about 5%. We think that's to do with the tropoectoderm, and we're meddling with a bit with that. And the risk of monozygotic twins is ever so slightly increased again, just because we sort of made that hole in the surface of the embryo and make it higher risk of splitting. So that is my little run through of PGT. I hope that was helpful.
Great. Thank you very much, Ellissa. Well, it was very good. Any questions?
Stunned into silence.
Yeah.
I think it's because it's Friday afternoon. Everyone must be half asleep by now.
Yeah.
You know, I'll ask one. So when you're doing a PGT, the euploid status, aneuploidy status is also tested.
Yeah,
all the time. Is that right?
It depends where you have your treatments. So of the 5 centres in the UK that do PGTM, 4 out of the 5 do PGTA as well at the same time. There is one clinic that don't do PGTA.
What is the rationale of not doing it then?
You'll have to ask them.
All right. Okay, that's great.
Just a quick question, Jay. Can I just ask, it may not be politically correct question, but what proportion of your patients are Asian, consanguineous couples?
A high proportion. And I think with the new overseas policy, we're starting to see that there are a lot of patients that would have been coming through that can't anymore, and that demonstrates very clearly that that's a high proportion of our patients. I can't give you a number, but I would say probably quarter. It's a high number.
I thought maybe higher than that. is any, I mean, I know it's not a thing to necessarily say, but is any value in trying to improve education or reaching out to those communities to say, actually, this is having a big toll on
Yeah, well, it's really interesting you say
on
that.
the
So I work in
on the burden
I
on both neonatal services and obviously your services.
So I did my registrar training in Bradford, and it was at the time when they were doing the Born in Bradford study. I don't know if you've heard of the Born in Bradford study, but that was a massive study, very much looking into the impact of consanguinity. And what was really striking in Bradford was the acceptance that these patients had. They came in with a miscarriage, or they had an IUD, or they had a baby with an abnormality, and they just accepted it. They were, it was part of their culture to accept this. And I think a lot of the outcome of Born in Bradford was about education. And, we're looking at 10, 15 years ago. And I mean, I don't know whether anyone's actually looked to see whether that's made a difference, but it is, you're absolutely right that education is really key. But there is, it's a cultural thing, and I know that there's been quite a lot in the press actually in the past couple of weeks talking about this. Interestingly, it's been quite high profile, talking about consanguinity and marriage of first cousins, and whether it should be made illegal in the UK. And I don't know whether that will actually happen, but it is something that has been sort of very topical. So it's interesting you ask that. But yeah, education is key.
I think it's the elephant in the room. I think it's a political hot potato, and as white clinicians, it's often a difficult thing to address. But I think if you're from the Asian Pakistani background, I think you do see that quite a lot. I see that, and I think it's something that probably does need a more national approach in terms of education and discussion, which I think people shy away from.
But like I say, it has been in the press this week. I don't know if you've been alert to that. It's been really interesting listening to the debates going on.
Excellent. Thank you.
Thank you.
Jen.
Fantastic presentation, Ellissa. Thank you so much. I think as a subspec trainee, I think